Welcome to Oral Bites Podcast with your hosts, Kate Boothman and Carl Horton.
And Thunderbirds are go.
Thunderbirds? Where did that come from?
Didn't they count down?
I think
5,
they
4, 3, 2, 1, and then used to take off.
They didn't go into a podcast, no?
No, don't know.
How you doing?
Yeah, I'm good, thank you.
Are you doing the Thunderbird action? What a treat. What a treat. Well, why don't we
Got the head
have
of
a little...
brain.
What,
Didn't
sorry?
have no there. Didn't have a big forehead.
Are we
Anyway,
really doing this? A podcast
Okay,
on
sorry.
Thunderbirds, yeah?
I'll focus.
Right, we've had a question. So we've been asked if nurses can scan. And when they say scan, they mean the intra-oral scan. So thought we could have a little chat about that.
Yeah, good question.
It is a very...
Yeah, we do get asked that, don't we, sometimes, when we go to the newer practices, when we take the scanner, because obviously we've got the Trios 5. Is it 5? It's not 6. 6 is the
Not
new
6.
one.
We don't need 6. Not yet.
We do.
We don't.
We do. Did they do a Trios 1?
Very good question.
Because we had
Well,
a 3.
You.
I don't remember. Anyway,
Probably.
sorry. Yeah,
Possibly.
I sidetracked. So, in essence, yeah, absolutely they can. But it needs, I think, sensibly, it needs some kind of formalised training.
Yeah.
You know, I think if you're going to sort of, how can I put it? Think of it in a defensive way, which is a shame. Not necessarily in a defensive way, but in a sensible way, because everything you need to learn. I mean, I remember the first. I'm sidetracking, but I'll get to the point. So I remember the
Sounds
first.
like you.
Yeah, off on that tangent. But I'm still talking about scanning. That first scanner we had, I was lucky enough. So I worked with a chap called John Pugh, and he had the iTero scanner, and it was like it came on they still do. They come on a cart. Some of them with a big screen, and you'd wheel it in. It was heavy. You couldn't really pick it up. You know, this was like a 2-man job. You know, like you get on some of those deliveries, and you'd wheel it in its cart, and it would blow cold air to keep the mirror cool from steaming up. It was quite bulky, size of a baby's fist, and then you'd pop that round and scan, and it was slow. Or I was slow, and the rep would come round and show you how to do it. It'd be there for the first few scans, as I recall, and it took a long time. So that was one that I learnt on, and it didn't put me off because I quite like new technology. So it was a gadget.
I was going to say gadgets.
Yeah.
You
So
love a gadget.
yeah, I do. I really do. So in terms of like, what it was showing, I thought it was amazing. But in relation to taking an analog impression, it was cumbersome. It was cold on the sensitive teeth, so patients didn't like that. It was bulky. It wasn't error free, because they stitch the images. The stitching wasn't great, but it was still okay. It worked. But you could see the potential. But I can understand how, in those days, it didn't take off as quickly as I thought it would because of the theory of it. Because of if you got to take an impression, a few minutes, do a scan, 20 minutes. And then, things evolved, the software evolved. You didn't have to take a big cart around. You could take a laptop, and then the scanner tips became smaller. The software improved, everything improved really, as things do with, technology. And it becomes easier, and then it becomes easier to learn and easier to train. So it's just like taking a picture. It's just a camera. You're just taking a picture of the teeth, but you're just doing it consecutively.
Yeah.
In very small increments. And, that they come around and they show you how to use it if you're using it for the first time. It's a fairly simple process, and, you can get great results. There's no mess afterwards. So I'm talking about scanning a little bit, but what I'm saying is that I had training, and on those things, it was difficult, and now it's much easier. And so I think if you can get your team involved, great, because I think it's an extra skill. And I think it's quite nice. I still like scanning, although I like the team to scan.
Yes.
So I like the nurses to scan. I do kind of like hand it over begrudgingly because I want to do the scanning myself.
We do
Yeah.
tend to get a mixed response, really, don't we?
Oh, yes.
With
Yeah.
the teams that we work with and have worked with. I mean, the majority, I've got to say, the nurses would bite your hand off to scan.
Yeah.
They absolutely love it. And I can see why, because as you say, it's that extra skill level. It's something relatively new to them if they don't scan.
Yeah.
But we've also worked with nurses that are just not keen, are they?
No.
Not keen. Very happy for you to scan.
Yeah. 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 And, can understand. I mean, sometimes, when you start out, it's new, so it can be a little bit frustrating. It can be a little bit worrying because I tend to find probably, I don't know because I'm not thinking what that person's thinking, but they're very, very gentle when they're scanning. That's my observation, and maybe too gentle because you can retract with the scanner. That's one common thing that if we're talking tips, is one common thing is that you can actually use the scanner tip as a retractor. And I kind of see that almost nervousness about using it like that. And so then what happens is the lip comes in and the tongue comes in, and, so it's getting that confidence. But yeah, I mean, absolutely. Can they scan? Yeah, absolutely. And, I'll be honest, I know some dentists that maybe shouldn't scan. I hope I'm not included in that. And it's different for different things as well. So, if let's talk about Neil, for instance, and he does a lot of the, the clear correct work. So all of his scans have to be, not all scans have to be, he needs a lot more detail in his scans.
Yes.
He needs a lot more of the features in terms of the teeth and the tissues everywhere. Because he's working, with that Invisalign concept of the whole mouth potentially, and how the trays are going to fit and that side. Whereas we need a lot of detail in a very small area, and then we need less detail in certain areas. For certain cases,
yes,
for instance, not for large cases. I'm talking about maybe a single implant. So there's that you can have a little bit missing. You don't need an upper 8 on there, or you don't need the palate so much because it's not relevant to the area that you're working in. So, it's akin to taking an impression.
Yes. Yeah. Well, I mean,
that's the way to look at it.
We also work with some practices that actually have dedicated scanning nurses. So, they have a diary, and their diary that day or that session, be it a morning or afternoon, is scanning, which works really, really well for them, doesn't it?
It does.
And they love it.
Yeah.
They love it.
Yeah, well, we think they do.
Well, I think they do. I think what you've said, though, is key as well, with definitely training, definitely, and I don't think any nurse would say any different. Of course, they would like to be trained in it, to be able to use it, any new skill. But it's what you pick up with different clinicians as well, those hints and tips that you're on about. The amount of times that I hear you exchanging a hint or a tip with the nurses, and they're like, oh, I didn't know. Oh, it's really good. Really good.
Yeah.
I think that's where you learn a lot.
Yeah, absolutely. Yeah, I mean, they can be a little bit. Yeah, they're changing it again, as I mentioned about the software and how it works and everything like that. But sometimes, that they can be. I want to say tricky, but that's not the word to use. But you can get some scanners that just don't want to scan tissues, for instance. So if they haven't got a reference, so if you've got an edentulous area, that can be a little bit tricky. And sometimes the scan body, the angle of your scanning tip, it's sometimes counterintuitive. So where you're trying to scan your scan body, which is for those of you that don't do implants, it goes into the implant fixture. It's like a little cylinder, and again, those have changed. So they used to create. Well, we had Peak, which were fairly straightforward, but they deformed, so they weren't really reusable for a great deal of time. And now we've got the sort of titanium-based ones. And what they do is they spray coat them or etch them. So it gives a slightly roughened surface so it doesn't reflect the light back as much. So the scanner picks them up a little easier. And it's knowing how much of that scan body that you need as well.
Yeah.
So you don't need all of it. You just need the reference point, which is the top, essentially, and then maybe part of the side. And then that goes into the software, and the software understands where that is in reference to the teeth.
Yes.
Obviously, you can't just take the top of the scan body and then go, yeah, that's great. But you don't need the whole tube inside and outside to be scanned. But I do see some people, if they miss a little bit, keep going and going at it. And I think, that comes from an understanding of what the actual software, the other end, will accept.
Yes.
And not accept, but, needs.
Mm-hmm.
So there's certain tips and tricks on how to capture that data when you don't need too much data. And again, the software's changed that. I remember the early scans, you'd get a little counter on the Trios, and it would start telling you off if you've taken too many images. And I think some of them didn't want to send, because obviously it's got to send that data to the lab. But that's all changed now. It's fine. It's very rare that we see that warning sign clock up. But yeah, I think simple answer is yes.
100%.
Get some. If you feel worried, formal training anyway.
Mm-hmm.
Some proper training, and then formalize that as well if you feel that that's appropriate for your practice. So you just jot it down that whoever's been involved has had formal training with so whoever is competent to train those.
Yeah.
So for instance, been scanning now for 7-8 years maybe. So I feel that I'm competent enough to train people, and I'd be happy to sign that off as a competent trainer. But I'm not an official certified trainer as such, but I've got competency in that, and therefore I'm quite happy to sign that off. I would be, personally.
I think a lot of other clinicians would be the same, such as Neil that we mentioned earlier. It's funny, really, the interaction with the nurses when they speak about scanning, because hearing them talk about it with a nurse that likes scanning and a nurse that's not as keen, the nurse that's keen is like, you rather mix alginate? They're like, my goodness. And the other nurse is like, no, I think I prefer that. So it's quite an interesting debate, really, because I've heard a couple of nurses saying it, and there's no wrong or right, because it is obviously down to preference. But I just think it was very interesting when they were like, you would rather mix an alginate?
To be fair, though, if you've had a frustrating day and you're going to mix a bowl of alginate or putty together, it's quite therapeutic, isn't it? Yeah. Running
Not if the
5 minutes late
patient's
again, are you, Mr. Horton?
Not if the patient's talking and you can feel that alginate going off.
Yeah.
But yes, like you say, long and short, nurses definitely can scan. And I'd always say to a nurse, if the only thing that's holding you back is because you're nervous or you're apprehensive, don't be. Give yourself the time to be trained, even if that is speaking to a clinician saying, 10 minutes at lunchtime. Don't let that hold you back. It is an amazing piece of kit. I think
it's an amazing piece of kit. Yeah. And it's you can practice on each other as well. So
absolutely.
It's great. It's great. Love it.
Certainly is.
Yeah. So yes, in essence, simple answer. Yes. Yeah. Well, that was longer than I was expecting to talk about it. So you're right about the cameras, maybe. But yeah, thank you very much.
Thank you.